Hello and a very good morning. It's good to see a quite crowded room unexpectedly. It's quite cozy. Thank you very much for coming to the Hologic Symposium. For those of you that are outside-ish in the door, we will record everything and the talks will be available on YouTube shortly after the conference. In case you have further questions, you can always visit us at our booth where we have a dedicated team that can fill you in on some of the details that you may not really see or hear very well. Without further ado, I'd like to introduce Mike Quick, our Vice President of R&D and Innovation, and he's the genius behind the Genius system, and he will chair the meeting. Without further ado, Mike, thank you very much for coming, and over to you.
Thank you. Good morning, everybody. It's a pleasure to have you all here. Again, for those of you that are in the foyer just outside, we apologize. It's great to have so much excitement and energy. We know it's going to get a little bit warm in here, but as Christian said, we will have the recording available for those that are not able to see from outside. So we have a great program for you. I'm going to try, let's see if we can get our technology to work here. We advance the slides, maybe? There we go. Very good. Excellent. We're off to a good start. We're going to start off, the title of our symposium this morning is the Advent of Digital Cytology and Cervical Cancer Screening Program. And we have three presenters to share with you their experience with the Genius Digital Diagnostic System. As Christian said, my name is Mike Quick. I'm the Vice President for R&D, and my team has been developing the digital cytology system for the past several years, which is now widely used throughout Europe and currently soon coming to markets all over the world. So we're really excited to introduce some real-world experience of what the system is. I like to start off with this slide. This actually introduces in one picture everything we're going to be talking about today. So the slide that Dr. Papanicolaou is holding up, conventional pap smear, we know that there were limitations and challenges with the conventional pap smear that ThinPrep really addresses, and it really brings us back to the original idea of why we developed ThinPrep in the first place. We really were focusing on imaging technology and being able to use image analysis for the review of cervical cytology. And so it all started with the ThinPrep, and that still continues to be the foundation. The second thing in the photograph is the microscope. I actually have one very similar to that on my desk as a reminder of where we came from. But we've seen introductions of new technology and replacements for the microscope. And then lastly, this, as you can tell, was a still photograph of Dr. Papanicolaou that we've now used artificial intelligence to make it come to life. And we're going to be talking about what AI can do when we look at cervical cancer screening. So those are our three topics we're going to be talking about today. And it's my pleasure to introduce our first speaker. We have Dr. Zaha, who's the senior obstetrician and gynecologist with specialization in cervical cytology at Cytomol Laboratories in Germany. And we're excited to hear her talk about digital cytology compared to the standard imaging system in her practice. So please welcome Dr. Zaha.
So thank you very much. And I hope I will show you a very nice experience. I'll talk today about digital cytology compared to a standard imaging system in the context of co-testing program in Germany. So I am a senior of obstetric gynecologist with a specialization in cytology in Germany that is possible. And I'm working for Cytomol the last 15 years, and I do have enough experience. And Cytomol is a large lab. We are 8 doctors. We are 6 gynecologists, cytologists, 1 laboratory medicine, and 1 pathologist doctor. And we have 27 cytotechnicians. The volume expected to see this year is about 600 samples. It's a big one. In 2000, we started using of liquid-based cytology, and Cytomol was the first lab in Germany introducing ThinPrep and liquid-based. In 2007, we started with the imaging computer assistant, and before we introduced the new system, we are going to do a study to evaluate the new system. In Germany, in 2020, it was a changing in the program of the cancer cervical screening. We started with a co-testing, and we are the first lab introducing ThinPrep in co-testing. from the same vial, the same material. We are going to do first the HPV test, and after that, seeing the cytology and ThinPrep. In 21, we started a evaluation study for the Genius digital diagnostic. That was the first contact with the system. And now 22 and 23, we are working in the routine, and we have an experience in the more of 400,000 cases with Genius. What's happened? The pap smear is, I love pap testing. I'm cytologist, you know, and is a 90-year-old test with a remarkable success of story. It's the most important cancer screening test. Thanks pap smear, we have a significant reduction of cervical cancer, the mortality of cervical cancer, but we have no technical improvements at introduction. The problem is, and there are a lot of papers and studies, and in Germany too, 50% of cervical cancer women, they do have in the last 5 years a normal conventional cytology. That's the problem, that the sensitivity of conventional cytology to find SYN2, SYN3 is about 50%. In our lab, I can 60%, but it's not so high. We need some to improve the sensitivity of the test. And why it's happened like this? Because we have some limits. No test is 100%. The limitation of the pap smear are because in 2/3 of the cases, we have problems of the smear taking, of the preparation errors. After that, we have screening errors. We have fatigue, overlooking rare objects, and the third of the case is the problem. And of course, we have problem with morphology, with the groups, with the clusters, with metaplasia, like this. But in the modern cytology, we can improve that step by step. We can improve the smear taking with thin layer or ThinPrep, or we can improve the screening errors thanks artificial intelligence and computer assistance. And the other morphology problems, we can improve them with additive tests as HPV or biomarker or dual stain, for example. The computer assistance in cytology, the begins goes back to 50s and 60s, but to the complexity of the cervix and an insufficient power of computer was no success at that time. And liquid-based cytology was a byproduct developed through this technique. And finally, in 95, 99, we had the first screening machines. In 2003 was the FDA approval for ThinPrep imaging system. And now we are working with Genius digital diagnostic system. ThinPrep imaging system is very good system. I think you have enough experience. Is computer assisted pre-screening is only for ThinPrep specimens. This system is going to do a densitometric nuclear analysis, find the 22 most suspicious focal ovules, select it for screening. Of course, if any abnormality inside, we need a full screening manually. We have the FDA approval and worldwide more than 1,000 systems installed. And that now the system is standard in cytology. And the imaging is doing like this. Abnormal cells have greater, darker nuclei. Therefore, the algorithm is looking for the greatest and darkest objects. They do not pay attention to overlapping nuclei, which also appear great and dark. And in contrast, they look for nuclei groups, which correspond to glandular or endocervical cells. This is the algorithm for ThinPrep imaging system. And the first study we made and test the system was the Reinzar study. It was a study in 21,000 cases. And we compared in that study conventional cytology with ThinPrep and with ThinPrep imaging system. And we are surprised to see with ThinPrep imaging system, the diagnosis for SYN3 and more is 4 times more than conventional cytology. And since this time, we are working only with imaging system in cytology. Okay, well, we have a system and it's working very, very good. Why is necessary to introduce digitalization and artificial intelligence now? In Germany, we have the problem of increasing shortage of cytotechnicians or cytologists. And cytology has a higher inter-observer variability. And in Germany, in the future, by increasing HPV vaccination, and we have a very good screen population, the traditional screening will be more difficult because the finding for pathology will be less than now. And I hope in the future, cytology will be important for the HPV diagnostics further. And you need a further improvement of sensitivity, specificity, and assessment by external expert will be possible. Let's see the components of the Genius digital diagnostic. We have the digital imager, a very performant one. We have the cervical artificial intelligence algorithm, imager management server, and the review station. And the artificial, we have the problems in cytology, we have clusters, we have this three-dimensional cell groups between cover slip and glass slided. And that is the challenge, to interpret these three-dimensional groups in the two-dimensional photo or imaging. And if you are seeing the performance state, because they are screening in 14 different shades, and also those information is a very big data, is interpreted into these pictures, and the artificial intelligence is organized by rows and are bringing this suspections in our rows. In the first row, if you are seeing here's the first row, if you need more information, of course, you can click on it and you have, here are 6 different pictures, but you can have 12 of them. In the first row, are expecting to see the normal superficial cells. And in this row, we are expecting to see ascus and low cells. In the second row, for me, it's very important, the second row, because we are expecting to see metaplasia and small cells. And the most of high seal cells are in this row. In the third row, we have other distorted cells, additional for 1 and 2. In the fourth row, we are expecting to see glandular cells or clusters, different clusters. And the fifth row, we can see mycosis, trichomonasis, the infection. Of course, the algorithm is filled with all the rows. If it's nothing pathologically, will be only normal cells in all the rows to see. Let's see shortly our cytomol study. Here are 4 of cyto technicians doing the training. Before we installed the digital system, we had a training in lab. And the study was thought to see, our design was a retrospective blinded review of about 2,000 cases. 6 of them are not enough material to see with Genius. And we wanted to see the accordance of the pub groups, to see the accordance between thin prep imaging diagnosis versus Genius diagnosis, and to see non-inferiority for Genius diagnostic. It was interesting to see the screening time per slide, and in 2 months was possible to see all of these 2,000 cases. And in low seal and high seal cases, there was a histologically resolved biopsy there. And if you are seeing on the right, we have the Genius digital diagnostic finding, and on the left, thin prep imaging system finding. In the green area is the perfect match. The both diagnostic was identical. For example, we have 1,100 cases nil, so both of systems, and 238 high seal cases. But if you are going to see in this 8 cases, we have in this high seal, so with Genius diagnostic system, and nil with thin prep imaging system. Was right. If you are, we saw in the analysis that the concordance for the Genius was about 90% versus thin prep imaging system. That means in those 8 cases, 5 biopsy shows in high seal and 3 biopsies was seen 0. But we ate it a little bit, and we saw the follow-up of those cases. And if you are going to see the follow-up of these cases, the pub was high seal, remain high seal, and that means after the conization, it was in high seal inside. That means the biopsy didn't find the high seal. And for us, that means the accuracy of diagnosis with Genius was higher than thin prep imaging system, and is about 97%. Of course, it's important which person is doing the diagnosis, but not only the machine. We published this study in the Cancer Cytopathology. If you want, you can find it there. And important was for all cut-off values, and the result of this quality assurance evaluation confirmed that Genius technology is not inferior to thin prep imaging technology. Furthermore, we have a significantly more slides with higher severity, And for example, in a high seal group, we saw 18% Genius high seal versus 30% imaging system. And low seal and ASCUS, those cases were comparable between the two technologies. Let's see some cases made in our lab for the Genius. If you are seeing here is a young woman, 37-year-old, HPV 18 positive, and our diagnosis with adenocarcinoma in situ. You know, the problem of the Genius are this very hyperchromasia of the clusters of the groups, but you need a little bit experience. And for example, in these cases, if you are going to click on this group on this cluster, you can see here we have the suspected cell groups and endocervical groups, or in this other cluster, for example, here. And if we are going to see the other, this is typical feathering for adenocarcinoma in situ. And you can compare, you have enough time to compare them. If you are going to see, you have the elongated nuclei, you have the hyperchromasia, the thick membrane, the nuclei is not, they are typical for the feathering and adenocarcinoma in situ. You need a little bit training, but it's possible to see these cell groups. And if not, you can go to see under the microscope the preparat, the smear again. This is another interesting case. If you're seeing, it is a 44-year-old woman, HPV negative. It was the patient had a Mirena in the last 10 years. And there are not enough cells, only 3,900 cells inside. But if you are seeing, we have a lot of bleeding. We have this tumor diastasis and the small cells, the suspect high seal cells. You can recognize them. If you have experience in morphology, it's very easy to put the diagnosis, really. And for example, if you are going to see this area, what kind of cells are there? We have necrosis, we have this small dysplasia with keratin, hyperkeratin, or this. It wasn't cancer, and there are necrosis. Necrosis. And we have here some high seal cells, maybe they are tumor cells, I think. And on the other here, it was very interesting to see this area here because they are very, you see the elongated spindle cells, and it was our diagnosis, it was squamous cell carcinoma, and it was one, or these other groups we are seeing here. And for, for thin prep, the background bleeding is typically for a carcinoma. And you have to see bleeding is not normal. I have to pay attention of the cases. And this is typical for thin prep, this naked nuclei. If you are seeing that, this isn't high seal inside. And you have all the information. And if you want to screen, of course, you can screen it here. You can magnify, or everything can do it with Genius. Possible. And there was a squamous cell carcinoma in this case. But let's see this other cases, HPV negative young women, and it is in German system is PAP1 nil, or these other cases we have. It's very easy to put the diagnosis in the co-testing HPV negative, only one click and we have clear diagnosis. Here another cases was HPV negative and nil. So, okay, we saw our study. What's about our experience in every day in a routine? In Germany, is this institution, KBV, is giving us a benchmark and is not allowed, or is not a good quality if you have more ASCUS than low sales, and is not allowed to have more than 5% pathology. That means we have a strictly quality and data controlled, and there are our limitations in cytology. I compared first the group with ThinPrep imaging system in the older the 34 with co-testing system in the Genius digital system, because we are doing ThinPrep in a co-testing program. And we saw that, of course, we are going to find more ASCUS. With Genius, we are more analytic, the sensitivity is higher, but you have enough time to reduce the number of the ASCUS under the microscope. We're doing that in our lab. But if you are seeing, we can find more low seal and high seal cases, and we are still remaining in 5% pathological cases. And our quality of cytology, because we have a more low seal than ASCUS, is there. If I compare the conventional cytology in the women over 35, in that group, our quality of cytology is not such good because we have more asquith 2% than low seal, and we are not finding high seal at all with conventional cytology. And that's, as a conclusion, I can say that our data indicate a higher sensitivity of Genius technology to distinguish higher grade from lower grade. We have up at 75% shorter working time. Of course, evaluation of slides by several experts in different places worldwide is possible. And of course, we need some further studies are reasonable. But please don't be afraid, because the monitor, artificial intelligence, cannot replace the cytotechnicians. We need the cytotechnicians to do the diagnosis. Just improves your skills, because in Germany there is a limitation to see. You can see 1,000 slides per day. It's not possible. But the work we have enough time to see under the microscope only the pathological cases. In co-testing system is very easy to see the normal one, the NILM and HPV negative, and it are remaining only 5% pathology, and you can reduce that under the microscope. The quality of the screening will be better, but we need the cytotechnicians. Don't be afraid. So, and I think the art of interpretation is a human skill. The diagnosis is made by doctors, by cytotechnicians, by cytologists, and not by the machine, and that's important. So many thanks for the attention, and you can ask me.
Fantastic. Thank you very much. Our next speaker is Professor Alan Wilson. Alan comes to us from Monklands Hospital in Scotland, where he is the consultant biomedical scientist. And oh, we switched. Okay. Sorry, change in program. We actually have an external speaker who wasn't able to join us in person, but we do have them live via Zoom. So we have Dr. Stolte and Dr. Baumer joining us from Germany, and their talk will be implementing diagnostic performance studies to assess digital cytology.
Thank you. Good morning from Germany, and thank you for the opportunity to join this meeting as a Zoom conference. I want to present you the data from our prospective study. We just heard about the retrospective data from Frankfurt, and my theme now is, does the augmented guided cytology improve the overall quality in cytology? And I would like to present you the results from our prospective study. This is my colleague, Dr. Böhmer, and me. We are located in Hanover. We are running their colposcopy clinic, and we have a cytology lab where we analyze about 250,000 of cytologies a year. We are working with conventional cytology and ThinFrep as well. And we are working with Hologic for a longer time. So we had the idea to make a study to see if the results of the Genius system in prospective are comparable to manual screening of the ThinPrep slides. Is the digital cytology accepted by our cytotechnicians? Is the possible work performance comparable? And is the Genius system reliable and suitable for everyday use? What we are planning to do, we wanted to analyze about 2,000 to 2,500 cases. We started in August last year, and we had three groups of patients. The one group are the patients who were referred to our colposcopy clinic. The second group, patients who underwent surgery because of a CIN. And the third group we had, a smaller one, was a screening population from one of the gynecologists who work with us. So we have from these patients only the cytology results and no histological improvement. So if we see all these groups, the first group, this was the group of patients who were referred to colposcopy to our clinic. We all did, all of these patients got a smear taken on their visit. The smear was processed and the slide was blinded by a scientific assistant and first analyzed by the Genius digital system. And it was blinded again so that nobody could establish a connection between the both sides. And it was then screened by manual screening. Those are the results of the cytology. And on the other hand, we have the results of our colposcopy. So we have the colposcopy colposcopic impression, we have a photo documentation, and in most of the cases, we took a biopsy or an endocervical curettage. So we got our diagnosis from the colposcopic assessment, from the biomarker information and the histological result. And all of these data went into our database for the evaluation. The second group of patients, they all got a smear as well, and we all proceeded these slides in the same way. So they were blinded, first analyzed and screened by using the Genius digital system, and blinded again and screened by manually screening. And on the other hand, we have the data from our cone biopsy. So all of these patients underwent a colposcopy again in the operation theater. Then we did our procedure, usually a LEAP. We have a video documentation, and we have the histological result of the cone biopsy. And the third group of patients, we only have the smears. Those are the patients from the primary cervical cancer screening. And we did the same with the smears. They also got a liquid-based cytology. We had the slide screen using the Genius digital system, and then blinded again and used and screened by manual screening. At all, we could use the data of 20,024 cases. In 1,047 cases, we have histological results as an endpoint. And in 475 cases, we have only the information by cytology, because those are the patients from the primary screening. If you see how what diagnosis we could find in these 1,447 cases, we have nearly half of them with a normal biopsy. We have about 20% with low SIL, or in Germany, we use the CIN1. We have about 20% with high SIL, or moderate high SIL, in Germany called the CIN2. And we have 7.6% of really high-grade lesion, high SIL, severe lesion, even one carcinoma. If you look in detail on the histological results, the first group, the patients with no abnormal findings in the histology, a 100% accuracy we see in using the Genius system in 74%. There, the manual screening was a little bit more accurate. We have 84%, 100% accuracy. But if we all know, and if we heard before, the cytology has not such a very good sensitivity, even if you, or at least if you see the single smear. So the single smear is in a sensitivity at about 50 to 60%. So we decided to make diagnostic groups to say we use for this diagnostic group the adjacent results. So we have one step upward and one step downward in our diagnostic group. Because of the normal smear, we don't have a step upward. We use the 1 and 2 steps upwards. So we used for this diagnostic group also the ASCIS and the low SIL cytological findings. And so we have all of them in this diagnostic group. You might ask why we do have such a big amount of ASCIS and LSIL in this group when we didn't find anything in the histology. This is not a normal patient group. You know, all of those patients were referred to us by an abnormal smear outside or by an HPV positive finding. And if you see in this group, we have about 70% HPV positive patients. So this explains why we have this high rate on ASCIS or LSIL, because we see all these HPV findings in the cells. And that's why those are not normal cytologies, because they describe the HPV findings. That's why we have this high group here. The next group, the patients with low-grade histological abnormalities, or in Germany, the CIN1. We had 301 patients in this group, and we saw that the Genius makes a more accurate diagnosis than the manual screening. It was about 41% of the cases we diagnosed exactly with an LSIL cytology, But if we include the one step downward, the ASCIS, the one step downward, the ASCIS, and the one step upward, we have about 100% this diagnostic group that we found these low-grade lesions. The next group, the CIN2 in Germany, is in the Bethesda system. It's in a high cell, but a moderate high cell. We have about 309 patients in this group. And here we see the same picture. Using the Genius system for screening makes a more accurate diagnosis than the manual screening. But if we include the upward and downwards groups, it gets a bit better. But you might think, where are all those left cytologies? Did we say they were normal? No, they were not normal. In this group, which is a very heterogenetic group, also in describing the cytology, we had a lot of ASCIS, and that's why the numbers are so low here. And the last group are the high-grade lesions, the high cell severe. By histological findings, CIN3+, we had 118 patients in this group. There also we see a slight leading position of the Genius with a more accurate diagnosis of 85.6% compared to the 72% of the manual screening. And also we include the downwards and upwards parts. And so with the Genius system, we found about 95% of these lesions. We missed some in this group with manual screening. So the Genius system helped us to do a really better diagnosis here. How does cytological diagnosis correlate with the SYN diagnosis? If we put it all together, we have here this line that we say we are looking for the real 100% accurate diagnostic or occurrency between cytology and histology, and we see that the Genius system is there about 64.9%, and the manual screening slightly down this with 63%. And if we use our diagnostic groups, at the end we see that the correlation between cytology diagnosis and CIN diagnosis is better in the Genius system. This is a slight difference, but this difference is statistically significant, and so we can say that Genius helps us to get a more accurate diagnosis. The screening population, the 475 patients, we can also only say if there is a concordance in the results of the Genius system versus the manual screening, because we don't have the histology as an endpoint. If you see the green fields, those are the cases where we have 100% accuracy between so that the manual system and the Genius system set the same, and we see a concordance in exact diagnosis is about 85.7%. And if you use our diagnostic groups with upward and downwards, we have 86%. We are slightly lower than the data you just heard from Frankfurt. They were about 90%. The other thing is that we always need our cytotechnicians to do the screening, whether with the microscope or with the Genius system. We had 4 of our cytotechnicians trained on the system, and afterwards we asked them some questions. How did they feel to work with the system? And 4 of them said, so all of them said that it's more fatigue-free to work. It makes them safer to work with the system. They feel this work is more efficient than with the microscope. In Germany, it's allowed to screen 80 slides a day by a cytotechnician. And they said if they would regularly use the Genius system, they would be able to screen about 120 a day. So it's really more efficient. And if we ask them what system would they like to prefer to use in the future, all of them wanted to keep the Genius. So is it really reliable and suitable for everyday use? The Genius in our institute is running since April 2022, so we have it now for about over 1.5 years. And since then, we had to restart the system only 5 times by our employees due to an error. And only 2 times we had to call an engineer from Hologic to come over. And a very impressive number, I think, only 1.7% of the slides could not be processed by the Genius system. This is, in my opinion, a really low number. And I think we had more problems with the image before. So to come back to the questions from the beginning, are the results of the Genius system comparable to the manual screening of thin sites? We have to say yes. Is the digital cytology accepted by our cytotechnicians? Yes, it is. Is the possible work performance comparable? Oh, yes, it is. It's even quicker. And is the Genius system reliable and suitable for everyday use? I would say yes. So thank you for your attention.
Fantastic. Thank you very much for joining us Zoom. And we will have all the materials available after the conference again, as a reminder. And now on to our final speaker. We have Alan Wilson joining us from Monklands, consultant biomedical scientist, and he's going to be talking to us about implementing diagnostic performance studies to assess digital cytology. Alan, thank you.
Thanks, Mike, and thanks for the opportunity to speak to you today. So I'm going to speak to you about our experience with this system. We've been using it now for about 2.5 years, although we had a little inconvenient hiatus in the middle caused by the pandemic. So the research, this was partly funded and the analysis was done by Hologic, but my impression in the broader discussion is all my own. Oops, wrong way around. So the aim of this presentation is really to reflect on our experiences of using this in a diagnostic lab. We're a relatively small lab compared to the 2 previous speakers, and we have a relatively low cytology input because of our move to HPV primary, which we did in 2020. So I did this as a retrospective study. But if you note at the bottom, there'll be no data with this simply because the study didn't work as we'd intended it. And what I'm going to try and convey today is our learning from that study and how we're going to move forward to try and repeat the study and create some data. And our approach using it retrospectively, we will do again, but we will do it better this time and implement the learning that we've learned within the lab and also with working with Hologic. So we have a view. I'm not going to repeat any of the slides that have been presented by the previous 2 speakers. So it's clear that cytology has evolved. It was interesting seeing that footage of Dr. Papanicolaou so many years ago, and most of us in this room, maybe not. I'm looking at the ages of the people in the room, will remember the pap smears and conventional cytology. And if you look at where we were then to where we are now, and looking at this kind of technology is an incredible journey that we've had over particularly the last 25 years. But when we're making changes, we need that robust evidence. And it was really good from the 2 previous speakers to see that robust database. And that's what we need to do. We need to gather that data robustly to ensure if we make changes in screening programs that they are safe and minimize any harm. And I think there's particular pressures that will come on at the moment with the routine workload. And that's what I'm going to reflect. When we started in the study, was before the pandemic, and our modelling, and before we went live with HPV primary, and the modelling we did, and many of you will have done with the introduction of HPV primary, indicated in our head that we would have capacity particularly within our primary screening team, our cytotechs, to do this study. But what I think has been demonstrated by the move to HPV primary, that modelling work, I'm not sure in other countries, certainly was not robust, and we ended up requiring much more of a cytotech input to do our day-to-day routine work than we could commit to do the double running that a study like this intends. So there's a challenge to generating that evidence, and that said, it's running studies like this in a relatively small lab when we have workload pressures. And I'll give you a flavour that our turnaround time for HPV primary at the moment in our lab, we're turning the cases around within a few days. if it's HPV negative and normal. If we are doing cytology, however, our turnaround time recently in one of our 2 labs, we have 2 labs in Scotland, was close to 12 weeks for doing cytology. So, and that's actually worse than it was HPV before we moved to HPV primary. And those pressures impacted on how we could run this study, because it does take quite a lot of resource to do a parallel study such as this. So that's a little bit of a background on the Scottish lab. So in 2013, we fully converted to liquid-based cytology, ThinPrep, and following a 2012 study, a peer-reviewed study, we moved to the imager system. So we've been using the Hologic imager system now for about 11 years. And in 2023, we then started looking at this, but we've actually had that imaging system, the Genius system, in place in my lab for about 2.5 years. So we run 2 labs in Scotland testing samples for the screening program. We do about 180, our lab's relatively small, 180,000 HPV tests, 28,000 cytology tests per year. We've got 16 cytology staff, a mixture of biomedical scientists, that our terminology in the UK for cytotechs, and also cytology screeners. And we have got 4 medical staff and consultant biomedical scientists. So we have been using the imager for a while, and we demonstrated with our peer-reviewed paper, and that's persisted, that the imaging system that we've been using now has increased sensitivity, efficiency, and workflow over the last 10 years. And our hypothesis going into this study was the Genius system could further improve that performance. And also, I think there's a further element to this study, and a further advantage to this system. It's the ability to pool resources. We view one of the issues here is that we can then share work between laboratories, not just within Scotland, but potentially within the UK. Once you've got that digitized platform, it's a bit like digital pathology. Those of you involved in digital pathology, you can share those images for a second opinion anywhere in the world, in effect, by moving that around. And as workflow changes and staff resources drop, this technology gives you the resource to pool that resource across a wider geographic area, and to increase resilience of the overall service, as we have a shrinking cytology service. And particularly, I'm sure many of you struggle to recruit now, because cytology, sadly, is not viewed as a long-term prospect for many staff, and we are struggling to recruit. So I'm not going to go over the technology. We've seen enough of that already. So the initial data was based on over 4,000 cases reported by consultants. So I've been using this technology now to shadow report. So using standard microscopy for medical reporting, and doing my medical reporting, shadow reporting using a Genius system. And we've now got data for about 4,000 cases. So, and it's absolutely no doubt there's at least a 50% saving on time, more efficiency. So you can do the slides in about half the time, maybe a little bit less than you can using the imaging system. So it's a considerable saving. And again, as there is pressures in general and pathologists to move into, who are also often caught in large histopathology backlogs, this reduces the histopathology workload, the cytopathology workload for the consultant pathologists. So I think there's also a role for this internal quality control, possibly as a precursor to training cytotechs. There's absolutely no doubt you can do this quicker. In the UK, we currently use either what we call rapid preview or rapid review as our quality control steps. Using this even for quality control, I think, increases accuracy, and it also is significantly quicker than having to do a rapid review of the slide. I think we still have a piece of work to do to integrate this into the laboratory workflow. I think we are so used to having a glass slide driving the pathway through the slide, through the lab, sorry. But as we move on to virtual technology and onto images, we need to look at how we integrate the software within this system with the local information systems to make sure there's a clear pathway and a clear and robust system for monitoring that through the lab. So that was a study design. So we have been using the imager stain for over 10 years. So we took slides out of file. And I think it indicates, again, the robustness of the imager stain, that we took slides from 2017 and 2014. So slides are almost 10 years old, and yet the vast majority of those were imaged by the Genius system. So I think it shows you how robust that stain is. So we retrieved them. we anonymized them, and we blinded them to the cytologists. So it was a retrospective head-to-head design. We used the archive slides, and what we were comparing with actually was cytology was a primary screen test. So, but the results come back were when we started looking at the results. Now we'll move on to this. And this is the challenges we had when we started doing this. We didn't power it enough, actually, basically, when we took the retrospective study. So we didn't get enough cases with confirmed Sin2+ to make this a robust analysis. And that's why we're going to back and repeat it now, where our turnaround times are falling and we've got some capacity within the lab. So, and we didn't set clearly the definitions of what a mismatch was. So we were basically taking these slides from archive that we knew the outcomes, and that's why we did it this way. We had the outcomes, we had the histology results already, and we had all that data in the laboratory system, so we could take those results and compare them with the results of from the same slides put through the Genius system. I don't think the basics of it was flawed. I think it was the implementation of it was flawed, and that was partly due to the resource issues that we encountered, partly during COVID and partly due to the modelling issue that we didn't have the staff to resource it properly. So there's a variety of issues, and I'll mention a few of these. So training's one. I think we were one of the first implementers of this, and I think we've been working with Hologic and Mike and the team, and I think we need to look at the training for staff in this, because there's no doubt this is a good system, but we need to look at the training needs to be intense, and some of this only comes with experience, particularly, as our first speaker mentioned, the hyperchromatic crowded groups, which I think we need to do a little bit more work on, particularly around the training. And data management, remember, this is, again, those of you with familiarity with digital pathology, these are big files to store. And I'm not sure what your storage facilities are like elsewhere, but in the UK, we store for 10 years. So basically, we will need to keep these images for 10 years. That's a lot of server material, a lot of IT infrastructure to make sure that you've got all those images somewhere that you can retract them if you need them, if you're doing an audit of your cancer cases. So these are all issues you need to think about when you're implementing this. And cloud storage may be the answer to this, and that's something we're working with Hologic on this as well. So it's been a really good interactive experience. We've worked really well with Hologic on this, and Mike and his team have been over in the lab. And I think what we need to do is further develop this algorithm, further develop this technology, because there's absolutely no doubt in my mind this is the way forward. So it's training I've mentioned, and I think it demonstrated that people adapted to this. We're all cytologists. We know we're quirky. We don't like change terribly much, although we became used to it over the last 20 years. And some of our cytologists took well to this. Others did not. Those that have been used to glass slides for 30, 40 years did not necessarily adapt to this. So I think we have to work with individuals in this as well. So the retrospective view was conducted, and we did identify major discrepancies, but again, we didn't define them clearly enough on the outside. So doing the audit of those, and when we looked at the results, the data wasn't robust enough to present here to you, and that's one of our failings. So, and we've touched on training as well. Sample size. So I think that when we do this again, we need to increase, when we do the retrospective study, we need to further seed that with significant numbers of abnormalities, and then we'll have those with confirmed Sin2 to compare with both arms of the study. So we need to do a larger one and seed it with more abnormals, because we didn't really get the significant numbers of histology that we thought we would. So as we move into phase 2, these are things that we've been thinking about. I've mentioned, I think, most of these already as we've been through. So we need to review the basics of this thing. This study is robust. We just need to look at it more clearly and have an eye to the outcomes, because we launched into this very quickly. Thought this was a wonderful idea, but it was only when we got the results back we realized we weren't going to get robust data from this. So, and we're going to, as I say, repeat the exercise. Now we've got our turnaround time for cytology down to a more reasonable level. And I think this element of bias as well is important, because I think when we did this, we didn't inform the staff clearly in what they were doing. when we were blinding it, and I think there's an element of the data we've got as to how whether there's a bias included in that. So we need detailed descriptions for the staff when we do this, when your procedure for confirming those abnormals and interpretation, and what we're going to do with conflicting results. And if we've got more than one screener involved, as we do with many of the abnormals, that we allocate them randomly, and we're clear what information they've got before they start in this study. And we've touched on the training issue. So the outcomes of interest is determining this, what we actually want. What we want is clinical endpoints to this, and we need to be clear on those before we move on to the second part of this study. And the outcomes, I say, must be clearly defined. And with sample size, I think I've talked most of these issues as well. Yeah, I think we've covered most of these. Results are anonymized, yes. And the other important one is delta. If delta is defined, if we're doing non-inferiority studies, and that's what we were looking to do. So my final remarks. So what we're looking to do here is, as we're all are here, is to try and improve what we're delivering here, to improve not just in terms of efficiency, but effectiveness as well. And I think there's absolutely no doubt, as you've heard from the previous two speakers, that this technology has a place. It's come time. As we move towards digital pathology, this is the sidearm for cytology. And there's no reason why they can't be done at the same time. The technology we're using for this, for digital cytology, is similar to the technology we're using for digital pathology. And for example, the screens supplied by Hologic in this are actually superior to most of the screens that we're using in digital pathologists are using for digital pathology. But what we don't want to do is turn pathologist rooms into airline cockpits with multiple servers and monitors and another layer of complexity. So what we're looking to do is, can we use those screens for both digital pathology and digital cytology so that they can move seamlessly between the two. And I think there's also a piece of work to do, as I said, about integrating this into workflow. But that will be done, and that will be individual to the individual laboratory and screening program. But my last point, my last word is initial data and feedback indicate that digital cytology is the way forward. And what it will do is will not only just improve performance, but it will improve resilience for the whole service, as we already described. So thank you for listening.
Fantastic. I want to thank our three speakers that we had today. Really appreciate you sharing your experience firsthand. For those of you in the audience, I think it'd be helpful to know just the context. We have just a couple minutes as we wrap up. Where we are, we have more than 60 systems installed for clinical use. And one thing, everyone's hearing all about AI, right? Everywhere you go, you hear about artificial intelligence. But how is it actually being used in terms of managing clinical impact for patients? We're not seeing a whole lot of that when you see, not just in our field, but across all of medicine. There's not a whole lot of practical applications. But one interesting thing to know, we believe that this is the most clinically used application for artificial intelligence today. More than 6 million women to date have been analyzed using the Genius system for artificial intelligence for cervical cancer screening. So it's really significant. It's a high volume test that really makes a big difference in the lives of patients. And so we're really excited to partner with you as we continue to make changes in the world for artificial intelligence. I'm going to close with one last point. And then we're going to have just a second for Q&A. If you have a question, we can make sure we address some of those. But when I was planning to come here a couple of months ago, I, like many of you, probably used a system where you log in to put your travel plans in. And how many of you use Google, where you start typing things in and it prompts you to say, is this what you meant? And starts finishing your response? Well, when you type a destination in and you start with BU, it does that alphabetically, right? What comes before Budapest? Bucharest, which I did not realize until last week when I looked at my flight tickets and saw I was going to Bucharest and not Budapest. So it's really important to remember that the human in the loop is an important part of the system. And we need to continue to remember that this is not a replacement for what we do. What we do is critically important. We're giving ourselves new tools to help us be more efficient, but we have to do it in the right way. And I think our speakers have talked about that today and really appreciate your time. Thank you very much.